Everyone. Welcome and thank you very much for attending the webinar today. For anyone who doesn't know me, my name is Dr. Bethan Evans and I'm a Senior Lecturer in Geography and Co-Director of the Centre for Health, Arts, Society and Environment at the University of Liverpool. It's fantastic to see so many people here, and we're really excited to be able to share the outputs of what's been 18 months worth of work for our team, underpinned by much longer work by Chronic Illness Inclusion. What we're going to be talking about today is launching a series of outputs from a research project funded by the British Academy Leverhulme Small Grant, along with some additional funding we've had from the University of Liverpool and Liverpool Hope University. As well as the members of the team that you'll hear from today, the project has also been informed by an advisory panel, and we had input from student interns at Liverpool Hope University and a medical student at University of Liverpool. So we want to thank them for all of their input to the project. So the project team that you'll hear from today includes Morag Rose and myself from the University of Liverpool, Anna Bay Pereira from Liverpool Hope University, and Anna Ruddock and Alison Allam, along with Catherine Hale from Chronic Illness Inclusion. So the outputs that we're going to be launching today include 6 policy briefs, which combine together to form a report. We'll be launching also an animation and a medical education kit. So the way the webinar will work, we're going to play the animation after a short introduction. Then one member of the team will give a brief introduction to each of the policy briefs which make up the chapters in the report. And then we'll give a brief overview of the education kit as well. There'll be time to ask questions using the Q&A, to add to our Padlet board if you have thoughts or reflections. And we'll also finish by launching a new project that we're about to start that builds on this research, with some opportunities for people to get involved further down the line. Okay, so without further ado, let's get started. Before going into the animation, just some background on the research, and this is covered in brief 1 if you're going to go and read the report or the briefs later. So many people probably know what energy limiting conditions are, but for anyone who doesn't, they're also sometimes referred to as energy limiting chronic illness. And they're terms that have been developed by Catherine Hale and colleagues at Chronic Illness Inclusion in order to provide an umbrella term for conditions in which people experience energy impairment and debilitating fatigue. So this includes conditions such as fibromyalgia, MECFS, musculoskeletal, neurological and autoimmune disorders, along with long COVID and others. Estimates by the Department of Work and Pensions indicate that 1 in 3 disabled people in the UK experience impairments in stamina, breathing or fatigue. ELC therefore provides a vital term to explore shared experiences of energy impairment and the impacts that this can have on people's lives across a disparate group of largely hidden people with a range of different conditions, but who are a growing section of the disabled population. And Chronic Illness Inclusion's work has therefore been foundational in establishing ELC or ELCI as concepts. And it's fantastic for us to have been able to work and partner with Chronic Illness Inclusion for this project and for future projects. So before I give some more background on the research, I'm going to hand over to Catherine Hale, who's the founder of Chronic Illness Inclusion. Over to you, Catherine.
Hi, thank you so much, Bethan, for that lovely introduction. It's really fantastic to be here with so many people, I think almost 120 people in this webinar, which is amazing. So I'll just give you a brief background. I was not involved in this particular project the last 18 months of work with Bethan, but my role has been to collect the testimonies, the evidence, if you like, on which the project was built. So I'll just share a bit of background about how that came to happen. So in all the research that I'd done with Chronic Illness Inclusion, that we'd done together, I always felt that there was kind of something missing in a way. So Chronic Illness Inclusion project was all about exploring chronic illness through the lens of the social model of disability. So that means putting aside symptoms, sickness, doctors, treatments, cures, all that kind of medical stuff, and focusing instead on how we can advocate as a group for changing the way society responds to chronic illness, so that, you know, while we're waiting for that cure and those treatments, we can nonetheless live life as fully as possible and ensure that our lives have meaning and purpose. So that obviously entailed looking at social policies and systems of support for disabled people. But what we kept coming back to was that however good or bad those policies or support systems are, they're only helpful if your status as a disabled person is taken as a given. And what we heard time and time again in our forums and surveys and the research that we did was that our status as disabled people is too often contested, disbelieved, or even denied. So as much as we'd like to get away from the medical model of chronic illness sometimes, the fact is that in our society, medical diagnosis and that medical validation, if you like, of our experiences of disability are kind of needed to sort of endorse our status, if you like, and act as a gateway to the support we need as disabled people. And you can see any cursory look at social media communities for chronic illness online. You see that time and time again, the most common a topic or conversation that brings people together is what we talk about most is our encounters with doctors and healthcare professionals and healthcare systems. And those encounters and those experiences seem to really contain the core of our oppression and those experiences of disbelief. And the term you'll probably have come across if you're in those communities is medical gaslighting. So recently there was an article in CNN by Diane O'Leary, where she says that apparently the hashtag, you know, the way that conversations are indexed or tagged on social media, hashtag medical gaslighting has now more than 262 million views on TikTok. And if you look under that term, you find thousands of first-hand stories from patients, mostly women, Diane says, who say doctors have ignored, minimized, or dismissed their symptoms as stress or anxiety, often with severe consequences. Medical gaslighting, she says, can kill women and girls. It's well known that heart disease is the #1 killer of women, and yet studies suggest that we're twice as likely to have our cardiac symptoms attributed to mental illness. O'Leary says that this kind of gender bias or sexism, if you like, happens systematically from within medical training itself. Doctors are taught that women are 10 times as likely to suffer psychosomatic illness than men. So there's no doubt that in terms of health outcomes, disregard and disbelief and the way that that happens systematically can harm and even kill women. And I think that awareness of that seems to finally be growing, because in 2021, the Department for Health and Social Care consulted on women's health and healthcare experiences. And many of the questions in that consultation were about women, the experience of being listened to by healthcare professionals. So when that consultation came out in 2021, for me, it was really an opportunity to go back to what I had felt was missing really from the work and collect evidence about, yes, women's experiences of not being listened to in that medical context, especially when you have an energy limiting condition that's disabling but invisibly so, and not just socially invisible, but often medically invisible, because these things are so difficult to measure and see. But beyond being listened to, I wanted to ask about, you know, our experiences of being believed, and what are the impacts of not being believed, apart from obviously the very crucial impact of healthcare outcomes and health outcomes. What are the impact of being disbelieved on our relationships, our closest relationships with family, colleagues, neighbours? What's the impact of being disbelieved on our self and self-worth? And of course, what's the impact of disbelief on our access to the support that we need to live as fully as possible, whether that's through reasonable adjustments at work, social care, social security. So what I want to finish with is the realization that these principles of disability rights and independent living, in a way, none of them can even come onto our agenda as people with chronic illness if our status as disabled people is contested because of a medical system that's stacked against us. So to me, disbelief and disregard is an important medical issue, but it's more than a medical issue. It's also a disability rights issue. And I hope that's what we're going to hear more about today from the researchers and the speakers. So thank you very much. I'll leave it there.
Thank you, Catherine. So this project then, as Catherine talked about, analysed the research that Catherine did to feed into that Department of Health and Social Care review of women's health and wellbeing in England. So response to the survey was overwhelming, with 962 responses, and Catherine analysed the quantitative data in order to write a response for that review, but there remained 195,000 words of qualitative data from the 14 open questions on the survey that needed to be analysed, and these are the data that we've analysed in this project. So people who responded had over 40 different chronic health conditions, and given the remit of the original inquiry, the majority of participants live in England, the majority were cisgender women, but the survey did capture some experiences as well from transgender, non-binary and gender non-conforming people, and also from people elsewhere within the UK and beyond. The survey is limited in terms of diversity in race and ethnicity, with 91% of respondents identifying as white British, and this is something that we're keen to address in future research. But with such a large survey response overall and detailed qualitative data, we have been able to pull out and see important experiences documented from participants from diverse backgrounds and with diverse experiences. So one of the core aims of the project was to raise awareness of the experiences of energy limiting conditions amongst a broad audience. So in order to do this, the brilliant animators Stacey Bias and Elle Rose have produced an animated film for us which brings to life stories from the data. So I'm delighted to be able to launch this animation here today and give you all the first look at it. Thank you to Stacey and Elle for doing such an amazing job producing that animation. We hope it might be useful for education as well as awareness raising, that's hard to say, amongst the public in general. And we encourage people who want to share it with friends or family, or if you're in an organisation, share it with the people that follow you. You'll be able to access it from YouTube and from our web pages after this webinar. So we can briefly come back to discuss the animation in the Q&A later, but for now what we're going to do is move on to outline what's in the policy briefs. We'll cover briefs 2 and 3 before we take a short break. So I'll hand over now to my colleague Morag Rose, who's going to talk through brief 2.
Hello, as Bethan said, I'm Dr. Morag Rose, and I'm one of her colleagues at the University of Liverpool. I've been emailing some of you when you had questions about the event, and a quick apology if you struggled to get in today. We have recorded and will be recording the whole event if you need to catch up. So brief 2 in the policy documents builds on what we've just seen in that fantastic animation, and it's about the negative impact of disbelief and disregard on people's mental health and well-being. It does real psychological harm, as demonstrated both by the animation and the quote here that disbelief made me feel worthless. This is a huge and very troubling problem. So our survey showed that 75% of respondents felt they were often or very often not listened to by healthcare professionals. And we feel that this provides an alarming picture of medical neglect, disbelief, disregard and stigma, which, as we said, negatively impacts people's mental health and well-being. And we strongly believe that this is what amounts to an abdication of responsibility and a duty of care on behalf of medical professionals. Participants told us that they often experience disbelief and disregard as being rooted in medical sexism and intersecting forms of discrimination. So this quote was illustrative of many, where somebody told us, "My confidence is at an all-time low after several poor GP consultations in 1 year. I was made to feel like a problematic, at that age, female. In the end, I would take my husband for support, and so I was taken seriously." Several other people told us they would borrow men to feel they needed to get credibility. There is a really damaging impact on mental health from being constantly disbelieved and disregarded. A couple more illustrative comments. "It knocked my self-confidence and self-belief that I know my own body. It made me start to doubt myself." This very powerful and troubling comment. "I have been made to feel like a liar, disrespectful, unbelieved, humiliated, judged, worthless, a scrounger, and suicidal." So this awful negative impact is absolutely devastating and has other real and tangible and very damaging ways it manifests as well. So, for example, disbelief can lead to avoidance of healthcare, as people told us. "I have been traumatized by medical gaslighting to the extent that I am frightened to go to the doctor now. When I do go, it takes me days to recover." Someone else said, "I stay away from health providers as much as possible, and I have on occasion become very unwell by avoiding or delaying asking for help." This also has an impact on relationships with friends and family. So, as one person puts it, "Because healthcare professionals dismiss and neglect me, my family now question how serious my conditions are and practically accuse me of malingering, exaggerating." So our recommendations to help fix this really are emphasised in the animation. So at the heart, we need medical professionals to listen and believe people with ELCs. They must take seriously the harms done to people with ELC due to medical neglect and disbelief. This absolutely begins with listening and believing and being respectful to people with ELCs. Thanks. Over to brief 3 now.
Hello, everyone. My name is Dr. Anna Bay, and I'm a senior lecturer in disability studies at Liverpool Hope University. So I'll be talking about the challenges of delayed or misdiagnosis. Some characteristics of this brief are shared with the previous brief, so I won't repeat some of what Morag said before. But one of the challenges highlighted by participants pertains to how long it can take to obtain a diagnosis, with this quote we have on the slides really highlighting what one of the participants has said. "For over 20 years, no one believed in terms of physical health condition." And we found this was a common occurrence in the data. Next slide, please. So another key finding that we found in the data was delayed diagnosis. As the animation shows, 31% of participants waited over 10 years for an accurate diagnosis. And the worse someone's symptoms become, the more likely they are to need specialist treatment in the future. And so the failure to believe and support people at the primary care level not only generates greater health inequalities, it also creates pressure on provision of tertiary care. Difficulties with diagnosis also influence other areas of people's lives, such as creating barriers in employment and access to benefits, which Vincent will talk about later. Another key finding that we had was misdiagnosis. So many participants had symptoms attributed to mental health problems, and many were also referred for unsuitable or in some cases harmful treatments. And this quote again illustrates some of this issue when this participant says, "Due to the excessive fatigue from long COVID, my GP would consistently say my symptoms were due to my mental health, anxiety, or depression." When it comes to misdiagnosis, the examples shared with us showed that this not only happens in situations where the cause of symptoms may be unknown, but also, and worryingly, in cases where a very clear explanation could easily be found if the correct investigations were carried out. So these situations can create unnecessary further suffering and the provision of unsuitable and even harmful treatment strategies. The other thing that we found is that mental health diagnosis is also can become a catch-all diagnosis where it's found. The other point that we found in the data was this issue of diagnostic overshadowing. So participants can find a difficulty with other possible illnesses or comorbidities investigated properly because health professionals tend to attribute everything to the original diagnosis. So one participant illustrated this by saying, "It took me 3 separate doctor's appointments over 3 weeks for them to take my abdominal pain seriously. It turned out it was related to my coil and not my fibromyalgia, as I had repeatedly been told and dismissed because of it." So real issues with the analysis of reading. And as Morag says, this really leads a lot of people to avoid care in the first place. There's also diagnostic overshadowing that is experienced by participants in regards to the issues being attributed to other things, in particular weight stigma, phobia have a big factors here in people being told that that's the cause of what they're experienced, of what they experienced. So 15% of participants who answered this question said that prior to their current diagnosis, their symptoms had been attributed to being overweight, obese, or too fat, or needing to lose weight, or overeating, or lack of power. And a quote from a participant illustrates this when they said, due to excessive fatigue from long COVID, my GP would often attribute the symptoms to mental health and depression. So in terms of the brief recommendations in my part, we certainly recommend training, that all healthcare professionals must have training on ELCs, and this must be based on up-to-date research and lived experience of patients, which we find is often not taken into account. We also have recommendations for better care overall, with quicker diagnosis and timely referral to specialist services, better patient pathways, quality and continuity of care, which are all really important, and also appropriate treatment of symptoms and management of symptoms, which is also important. So I'll hand it over to Bethan.
Okay, hi folks. So what we're going to do now is take a 10-minute break just to give people a chance to rest a bit. Welcome back. So I'm going to be kicking things off now by talking about brief 4, which is we've titled Pathway to Inequality, which covers the many ways in which disbelief in healthcare has implications for the rest of people's lives. Okay, so as Anna discussed, delayed or misdiagnosis is common for people with ELCs, and we've seen quite a few people commenting on that in the Q&A as well. This worsens health inequalities by making it more difficult for people to access benefits, social care, and adjustments in work or school. This leads to further inequalities as people with energy impairment then struggle to fight for their rights in the face of disbelief. And there was someone just posted this in the Q&A a few minutes ago. So, for example, this leads to problems accessing domiciliary care, so getting health care within the home for people who are house or bedbound. As one participant explained, "I'm housebound and needed some blood tests. My GP refused to believe I am housebound and repeatedly stated that I'm too young." Many other participants who similarly are housebound but not believed by their GP mentioned similarly being unable to access basic screening or immunisation programmes as a result of not being believed to need domiciliary care. In employment and education, then, a lack of diagnosis or support from a GP or specialist means that people can't access reasonable adjustments, leading to them underachieving or dropping out. For example, one participant explained that without a formal diagnosis, I struggled to access disability-related learning and exam adjustments at university and school. Another explained that their employer has a narrow view of disability. They don't understand energy-limiting conditions and chronic pain. I feel like I have to regularly justify and prove my health difficulties to access basic accommodations. In fact, 46% of survey participants said that medical disbelief had a negative impact on their relationship with their employer or colleagues. As a result, some participants reported that not having access to reasonable adjustments has meant that they've lost their job and with it financial independence. For participants seeking benefits, medical disbelief is also a barrier. 61% of participants said that their experience of being disbelieved by a health or care professional, particularly GPs, had a negative impact on their ability to access disability benefits and services. As one participant explained, without a doctor's support, I've always been thrown back on the DWP's assessors, which in turn always leads to appeals and court action. The stress of this in itself has increased my level of disability substantially. So many participants spoke about the benefits system as a hostile environment that required a fight through multiple appeals, some needing to get their MPs involved to access the support that they needed. For some participants, this fight took them well beyond their energy limitations, resulting in relapse and worsening health. Others were too scared of relapse to enter into this fight. As one participant explained, this was going to leave her in a desperate situation. She said, I've not attempted to claim disability benefits because, ironically, I feel too ill to face the fight that this would entail. No longer in work, I'm living off the stub of some savings. When these run out, I don't know what I will do. So what do we recommend? In addition to getting timely diagnoses, people with ELC need support and advocacy when accessing welfare, social care and reasonable adjustments in education and at work. As many ELCs are fluctuating conditions, the legitimacy afforded by medical professionals is vital. At present, the responsibility for navigating welfare and benefit systems falls on people with limited energy. And this can't continue to be the case. These systems need to be reformed so that people with limited energy aren't making themselves more ill in order to access that support. Finally, where people with ELCs do experience discrimination, they need support making complaints and appeals. And now I'll hand over to Anna to talk a little bit more about intersecting forms of discrimination.
Thank you, Bethan. And hello, everyone. My name is Dr. Anna Ruddock. I'm an anthropologist and a founding member of Chronic Illness Inclusion. I'm going to share some highlights from our brief about intersectionality. Intersectionality is a concept developed by Black feminist scholars that helps us to understand how different forms of oppression combine to influence a person's experience. The title of the brief, which is a quote from one of our participants, makes this clear. It's called Intersecting Identities Make It More Complex to Access Services and Healthcare. So we've already heard today about how sexist approaches to energy limiting conditions influence the disbelief and the disregard encountered by our participants in multiple ways. I'm going to build on this by showing how these experiences are exacerbated by other forms of oppression, which intersect with sexism, including racism, ageism, homophobia, transphobia, fat phobia, and ableism. One of the most striking findings of our research was that 75% of participants said they had often or very often felt they were not listened to by healthcare professionals. This number rises to 85% for LGBTQIA+ people, 81% for mixed race participants, and 81% for participants younger than 45 years old. While the limited diversity of people who responded to the original survey meant we couldn't do in-depth analysis of these themes, as Bethan mentioned at the start of the webinar, the findings that we do have are important, and they show a clear need for more focused research into the experiences of people with ELC who are part of disadvantaged groups. About race and ethnicity. Some participants explained that their experience of racism in medical encounters intersected with sexism and ableism, and this made it difficult for them to access appropriate and respectful healthcare. One participant told us, in addition to racism, sexism is an issue, and I have experienced it from the medical consultants. They have not been particularly helpful, not been interested in finding different, less invasive options, and they can be dismissive and lack bedside manner. Participants also referred to racist terms, as noted in the animation, such as Begum syndrome or BBitis, used to dismiss the legitimacy of South Asian women. One respondent told us so much more needs to be done, especially for women of colour who are referred to in derogatory ways. As a result of the combination of racism and sexism in the healthcare system, some participants explained that they now avoid seeking help altogether. Age. This chart shows that experiences of disbelief and disregard from healthcare professionals were shared across the life course, with more people aged 35 to 44 saying they very often felt that they were not listened to. Younger people described symptoms dismissed as growing pains or just being a teenager. One person said, "I was told I was too young to suffer this, so my concerns and symptoms were irrelevant." But some older women also described feeling overlooked or ignored, which they attributed to their age. "As far as my GP surgery is concerned," someone told us, "I am now an old woman of no importance." Among our LGBTQIA+ participants, some described experiencing healthcare spaces as heteronormative, where the assumption was that people were heterosexual or cisgendered unless they disclosed otherwise, which exacerbated feelings of being unseen. One person said, "Make healthcare a place where people can be honest about who they are, in my instance, as a gay woman." One participant reported experiencing homophobia in the form of the attribution of symptoms to their sexuality, as you saw in the animation, saying, "Specialists said my problems, chronic pain, etc., were due to lesbianism." For transgender people with ELC, the difficulties of accessing good medical care are exacerbated by the difficulty of accessing appropriate healthcare more broadly. For example, one participant told us, "My GP did not believe I needed HRT as a post-op trans woman and withheld it for some months." Body size or weight. Institutionalized weight stigma or fat phobia has a significant impact on people's access to healthcare. Of participants who answered the question, 15% said that prior to their current diagnosis, their symptoms had been attributed to being overweight, obese, too fat, needing to lose weight, overeating, lack of willpower, or lifestyle factors related to weight. As one person told us, "As an adult, my lack of energy and frequent illness was written off as depression or anxiety, or because I'm fat. I asked many times if it could be ME/CFS and was frequently told that that wasn't a real thing." As with other forms of disbelief, the way that medical fat phobia operates to overshadow and preclude exploration of other possible diagnoses leads to patients questioning their own understandings and experiences of their bodies, with negative implications for mental health. And it leads to people, again, avoiding medical care because they don't trust that their symptoms or their selves will be taken seriously. Class and wealth. So while the original survey didn't collect information about income or socioeconomic status, the qualitative data suggests that class and wealth, unsurprisingly, do play a part in mediating the impact of disbelief and disregard. Some participants explained that in addition to sexism, being working class or unemployed contributed to the disbelief that they faced. One person told us that the NHS have used my gender and working class unemployed status to suggest that I am neurotic, somatizing, have no insight into my illness, etc. After encountering disbelief from medical professionals in the NHS, some people who could afford to were able to get diagnoses by paying for private care. For people on low incomes or with multiple conditions, this may mean choosing which conditions to prioritize when seeking healthcare. As somebody told us, every health condition I have, I was not listened to at first. In many cases, I had to pay for private assessments in order to get the NHS to listen to me. For some participants, disbelief from medical professionals, employers, and benefit services led to the loss of employment, being unable to afford bills or food, or even homelessness. So our recommendations based on this brief are all about tackling discrimination. Tackling institutional sexism in health and social care is essential, but this isn't enough on its own. Intersecting forms of oppression must also be eradicated. More inclusive services grounded in respect and belief that address intersectional marginalization are vital. Much more research is also needed into the intersectional nature of ELC experiences. And speaking of research, I'll hand over now to Alison to talk us through our final brief.
Hi everyone, my name's Alison and I'm also a founding member of Chronic Illness Inclusion. So I'm going to talk to you today about brief 6, which is making public and patient involvement engagement more inclusive to people with energy limiting conditions. Next slide, please. So I think that these 2 quotes sum up the key message from the research regarding the need for women with energy limiting conditions to be included in research. One participant said, "Women need to be involved in every step of the research processes, not just included as participants." And another lady said, "We need a huge cultural shift in women's healthcare, investing in research for women's health and drawing on women from all walks of life and actually listening to what they have to say." More broadly, drawing on research findings, participants within PPI highlighted the need for involvement engagement throughout the research process. By this, I mean from the conceptualization of the idea right through to the dissemination of findings. To be seen as equal partners working together with researchers and those living with energy limiting conditions. And first, finally, valuing experts by experience, again highlighting the need for equality and challenging traditional hierarchical understandings of expert. As many of you know, PPI is frequently a requirement for research funding, but is often inaccessible to people with energy limiting conditions. Next slide, please. So our recommendation is very succinct, really. It's around making PPI accessible. In terms of how you actually do that, the participants said, understanding energy limiting conditions. By this, we mean that researchers, funders need to understand the unique challenges and barriers faced by people with energy limiting conditions. Prioritizing accessibility, either establish a support a supportive culture that prioritises accessibility and adaptability to consider energy impairment. Examples include online meetings, shorter meetings, supporting people to have cameras off if they need be, or be in a darkened room, using accessible platforms and methods of communication. The third point acknowledges that even with these access provisions in place, not everybody with energy limiting conditions can participate in real time. As such, having PPIE opportunities that enable people to participate in their own time, perhaps over an extended period of time, and as and when their fluctuating conditions allow, is really important. To summarise, it's about allowing participants to pace their own engagement. Minimising cognitive fatigue. I think there's a real need for researchers to simplify tasks and provide clear, written, recorded instructions to try and mitigate the cognitive fatigue. And finally, around providing adequate financial support for participants. Budget time and resources to support the inclusion of people with energy limiting conditions. Reimbursement of participants' time, covering the costs of personal assistants or carers, and advice about how payments may impact on any benefits. Thank you, and I shall now hand you back to Bethan.
Just get rid of this box. Okay, so before we take our second break, I'm going to tell you a little bit about the other output that we're launching today, which is our medical education kit. So as Anna explained earlier, one of our recommendations is for better training for medical professionals. And as we saw at the end of the animation, where participants have had respectful, supportive healthcare and been believed, this can make a huge difference to people's lives. So as a result, we've produced a medical education toolkit, which provides resources for a 2 to 3 hour training session that can be adapted for different professionals. This has largely been developed by an intercalating medical student at the University of Liverpool working in medical ethics, Hannah Kingston, who's worked with the project team to develop the resources in this kit. So the toolkit is mapped to General Medical Council graduate outcomes for medical students, but can be adapted for other healthcare professionals, so nurses, occupational therapists, other specialists as well. It contains a PowerPoint presentation, some worksheets for 3 different activities, and some role profiles for a role play activity, which would get students taking mock histories from patients who have energy limiting conditions. We've also included a list of resources and further reading. In terms of the learning objectives, what we hope is that if people pick up this medical kit and use it with students or in training, by the end of the session, the people taking that would have a better knowledge of energy limiting conditions, would understand the problems that people with ELCs may face accessing health and social care, would be able to evaluate the impact of bias and discrimination on access to healthcare, would understand that pathway to inequality that we've been talking about, and be able to give examples of how disbelief might impact other areas of people's lives. So that's one of the activities, as well as identifying then in another activity how healthcare professionals can better support patients to remove some of those other kind of implications for other areas of their lives. And finally, the role play activity hopefully will help them understand how to take a history in a way that demonstrates respect and validates patients' experiences. Whilst the problems people face accessing appropriate healthcare are overwhelming in our data, like I said, as mentioned at the end of the animation, there are examples as well of good practice. They're few and far between, but there are supportive doctors and other medical professionals out there. And several participants said that finding a supportive GP or healthcare professional had made a huge impact in making their lives better. So if you have people in your networks who might be interested in using this toolkit in medical education, please do pass on the details. It will be available to download from our website. Okay, so we're now going to take another 10-minute break before coming back for the Q&A and to launch our new project. Hey folks, welcome back. I'm going to hand over to Morag now, who's going to chair the Q&A session. Because this is a webinar, we can't turn microphones on for attendees, so please do type your questions in the Q&A box.
Thanks very much, Bethan, and thank you to everybody who's been commenting and questioning in the Q&A box or on the Padlet. Much appreciated. Now, we won't have time to deal with all the questions and issues today, but we will be writing a blog post that we hope deals with most of them. And lots of questions have come in about sharing of resources, and absolutely, yes, they will be available on our website. We will send links to everyone who's booked through Eventbrite. So if anyone has slipped through without doing that, please just make sure we have your address. Looking at the upvoting questions on the Q&A, the most popular question that's come in is from Polly. And actually this was reiterated in different ways by other people. And they've asked that, please can we talk about advocacy burnout? Several other people also talked about how can we find advocates when we as people with ELCs are by definition exhausted and often struggling with multiple oppressions. So I'd like to put that out to the other speakers if anyone has any thoughts.
Yeah, I think this is really key because often the people in chronic illness communities, we support each other, and so there is definitely much more of a need for advocacy services to be able to provide support free of charge to people who don't have that energy and whose families or friends don't have that energy to be able to fight systems that are increasingly hostile. Alison turned her camera on as well.
Yeah, I mean, again, I fully agree. Also, the point about being traumatized vicariously, isn't it? When you kind of listen, when those stories resonate with yourself in the role of advocacy, you just need to be really mindful of your own, what you can and can't manage, I think is the key message, both in terms of sort of supporting yourself, but also supporting or advocating for others.
Thanks. Catherine has raised her hand. Then after Catherine's comment, I'll move on to another question, if that's okay.
Hi, sorry I don't seem to be able to turn my video on, but I just wanted to add my personal kind of thoughts. Oh, here we go. My personal thoughts to that question is that I myself, as the founder and director of Chronic Illness Inclusion, did experience a burnout where my efforts to sustain the organisation and our collective efforts were way more difficult than I had anticipated. I was lucky enough to get a small research grant through Four Nations Disability Consortium project via National Lottery to start the research. But then when it came to continuing the organisation, it was a very dispiriting experience, because while there were real allies in the disability sector, the disability rights community, who had seen the need for this research, who realised that people with chronic illness and energy limiting conditions were didn't really have the voice, were marginalised in many ways from the disability rights community. And so it was so heartening that was recognised and the project was funded, and there was allies in that community, large organisations who wanted to work together and do another joint project where we would work on getting the language and the terminology of energy limiting conditions kind of incorporated within disability rights at government policy level. And sadly, what I found was that funders, I won't name them specifically, but have such a, within the kind of funding landscape when it comes to equalities and marginalised communities, disability is so far down the agenda compared to other equality groups that I found there's a real lack of understanding and engagement from the mainstream funders when it comes to disability generally. So for them to understand that there was a marginalised community within the disability sector, that they just couldn't grasp it. And so it was a a big piece of work that would have, hopefully sustained chronic illness inclusion for the future, that failed. And yeah, so I drew from that whilst we have allies, and I hope that those allies will keep supporting us within the disability rights movement. The sector as a whole is so underfunded and so marginalised, and obviously all marginalised groups are struggling for funding at the moment anyway. So I don't have the answer, but that's just what I wanted to add, really, as a reflection.
Thank you. Just very quickly, to short, but doesn't mean they're easy to answer questions, if we can have brief responses from anyone. So Ruth asks, should fatigue be specifically added to medical records? That was one of several questions relating to different diagnostics and conditions. And Sam asks, how do we counter the comment that I don't look ill? So if anyone's got a brief answer to either of those about whether fatigue should be a specific diagnosis and how we deal with comments about not looking ill. Thanks.
I think this is where the work that chronic illness inclusion have done in developing the concept of energy limiting conditions or energy limiting chronic illness is really important. So this question about whether fatigue be recorded on medical records, and also someone else was asking about support services for people with fatigue. And I think we've seen that while there's in no way a perfect situation for people with chronic pain at all, that seeing chronic pain as something that kind of cuts across lots of different conditions has led to pain services and support that is specifically around that symptom rather than the diagnosis of the particular label of the illness. And I think, with energy impairment, that could be really useful, particularly in things like helping understand what support people might need who have energy impairment or fatigue, what kinds of reasonable adjustments at school might be useful, or what kinds of domiciliary or social care might be useful, without it being fragmented across lots of different conditions. So I think that's a really good question, and one that hopefully some of chronic illnesses inclusions work will help has set the ball rolling in terms of recognizing that. I don't know how we get around the how do you don't look ill. I don't know if anyone else wants to come in on that one.
There was an earlier question about media representations as well that I think relates to that too. Alison, sorry, you've got your camera on.
I don't think we'll ever get around you don't look ill comments. I just think it's knowing your crew, isn't it? And knowing your supportive network and the people who, genuinely do get it, and the people who perhaps in your life don't quite get it. That's not to say that they're not friends, they're not colleagues, they're not everything. But I think it's kind of just knowing your core support network, really, and not getting too engaged in it. That is their baggage, not our baggage to carry, I guess.
Thank you. Yeah, and I would hope things like our education toolkits and raising awareness and understanding might feed into a culture that begins to understand how important and damaging ELCs are. So on that, thanks again. We will answer some more questions in the blog. It feels ironic given the nature of our discussions that we have to rush on, but I'm going to hand over to Anna, who is going to have a quick feedback from the Padlet. Also, to just say to people that have raised their hands, I am sorry we can't put mics on, but if you want to add your comments or questions either in the Q&A or the Padlet or in an email to me, we will deal with them later. Okay, thanks everyone.
Thanks, Morag. We had similar questions on the Padlet. There are some questions about how we intend to kind of use the medical educational toolkit, and I was wondering, Bethan, if you could maybe talk about our plans of how we might do that, especially in the next project, because that might be relevant to this particular question.
Yeah, and I'll pick up on that a little bit when we launch the next project in a minute. that project is also going to include some workshops with medical professionals. With this toolkit, what we're hoping is that we can circulate it, get it picked up by medical schools, particularly by people who teach communication skills and kind of medical history taking within medical schools, to try and raise that awareness. One of the things we've done within that kit as well is use some of the new NICE guidance for MECFS to frame kind of how we might want people to be approaching and treating people with energy limiting conditions as well. So yeah, but we're very much for this project hoping that that toolkit might get picked up. We will circulate it around networks that we can find to circulate it around. If there's anyone here who does work in medical education, please do get in touch with us. And then in the next project, we'll also be having some conversations with medical students and medical professionals as well.
Thanks, Bethan. Something else that was mentioned was related to how difficult it can be for people with ELCs to have access to particular kinds of benefits. So an example that was given was a blue badge, and how difficult it is to have access to those kinds of things, because we are, I think the assumption of those processes is that people are either permanently incapacitated or they're able to function. So there's very little leeway in some of these processes to understand our types of conditions where we fluctuate and we have good days and days that are more challenging. And I think that's again part of the work that chronic illness inclusion is trying to change. And I would really welcome everyone to check their website and to join their social media channels and the work that they're trying to do. Because I think that part of that work is really to change perceptions about what chronic illness is and how it affects us. So I think that's probably one important step, is to kind of try to find ways of coming together as a community. Bethan, I'll hand over to you again.
Okay, so finally then, before we close, we want to launch a new project today. So this project is funded by the Arts and Humanities Research Council, and it's titled Imagining Better Futures of Health and Social Care with and for People with Energy Limiting Chronic Illnesses. So the new project builds on the research that we've been talking about today, but whereas the research today has very much been looking at what the situation is now and what people's experiences in the past have been, this new project turns to look to the future. So what we want to do in this project is ask people with ELCs to imagine how health and social care could be better in the future. So what might it look like, both for ourselves as people with ELCs as we age, but also for people who in the future will be diagnosed with ELCs. So what we want to do is kind of move this looking at the past to looking at the future. And to do that, the project will involve artist-led creative workshops. And we've got some great artists involved. So there'll be a range of different creative activities, including zine making, creative writing, and some fairy tale inspired workshops. All of the workshops will be online, and in line with what Alison was talking about earlier in terms of making research and engagement in research more accessible, as well as the online Zoom-based workshops, we'll also have some options for people to take part asynchronously, so via email or via messenger, in their own time and at their own speed over the course of a couple of weeks, rather than needing to be present on Zoom. So we're hoping that will allow people with more severe forms of energy impairment to also take part. No one needs any artistic skills to take part. The artists will be working with the people in those workshops. So recognizing that treating patients with complex conditions is difficult also for medical professionals. Like I said before, what we want to do is also engage medical professionals in this research and acknowledge that many healthcare professionals, some of whom are those who are doing very good practice and supporting people at the moment, are also operating in very difficult, very under-resourced institutions. And so there will be some additional workshops run by Healing Justice London for medical professionals and students to try and understand some of the challenges that they might face in adequately supporting people with energy limiting conditions. So if anyone's interested in getting involved, we will soon be opening recruitment for this project. And it's open to anybody with an energy limiting condition, and you don't necessarily need to have a diagnosis. Like we've acknowledged, it can take up to 10 years for people to get a diagnosis. So we're allowing people to self-identify with having an ELC based on the symptoms that they experience. So it's open to people who are over the age of 18 and who live in the UK. And we're targeting 3 different groups. So first of all, Muslim women, and there'll be some dedicated groups for Muslim women. Secondly, some dedicated groups for LGBTQIA+ people. And thirdly, some groups that are open to anybody who identifies as a woman, a trans man, non-binary, intersex, or gender non-conforming. And then the Healing Justice London workshops will be open to medical professionals and students in the UK. So if you're interested in getting involved, look out for an email from us. We'll be sending a feedback form for this webinar in the next couple of days, and there'll be an option to be added to a mailing list there. Or you can keep an eye on our website, as we'll announce opportunities to get involved there too. And we'll be giving people time to respond. It won't be first come, first served in terms of signing up for that. If there are any academics with energy limiting conditions in the audience today as well, Anna and Alison and I are also starting a new project on experiences of ELC in academia. So also keep an eye out for opportunities to get involved in that as well. So on that note, we're just 1 minute over the time. I want to really thank everybody who's come along today. We know for many people this will have involved using a lot of very precious energy. So thank you, and we hope you found the webinar useful and that you'll make use of the resources that we've produced as well. And finally, in addition to thanks to all of the people who've spoken today, huge thanks to Hayley for the BSL translation and to Tom for IT support, which has ensured this is run as smoothly as possible. So thank you very much, everyone.